Welcome to our video on methemoglobinemia and cyanide poisoning. Let's get started. Let's begin with methemoglobinemia. We'll cover the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Methemoglobinemia is a blood disorder in which a large amount of hemoglobin is converted to methemoglobin by the process of oxidation. Methemoglobin has a very limited oxygen binding ability, which is why it cannot carry oxygen as well as hemoglobin. The pathophysiology of methemoglobinemia has to do with exposure of hemoglobin that leads to the conversion of ferrous iron inside hemoglobin into ferric iron, resulting in the formation of methemoglobin. In turn, methemoglobinemia produces a leftward shift of the oxygen-hemoglobin dissociation curve, resulting in decreased oxygen delivery to tissues. The pathophysiology of methemoglobinemia has to do with exposure of hemoglobin to an oxidizing agent that leads to the conversion of ferrous iron, or Fe2+, inside hemoglobin into ferric iron, which is Fe3+, and this results in the formation of methemoglobin. The alpha and beta subunits remain unchanged. To illustrate how methemoglobinemia impairs oxygen delivery to tissues, consider this oxygen-hemoglobin dissociation curve depicting the hemoglobin saturation on the y-axis and the partial pressure of oxygen on the x-axis. Methemoglobinemia will shift this curve to the left, which, as you can see, makes it more difficult for oxygen to detach from the hemoglobin molecule and thus decreases oxygen delivery to the tissues. As stated several times already, exposure to an oxidizing agent is the primary risk factor for methemoglobinemia. Certain drugs can act as oxidizing agents and thus carry a risk of inducing methemoglobinemia in patients that take them. The drugs included in this slide are among the ones most commonly tested on exams, so let's briefly go over them. Dapsone is an antibiotic commonly tested in the setting of treating leprosy. Rasparcase is a recombinant urate oxidase enzyme used to reduce serum uric acid levels, often tested in the context of tumor lysis syndrome. Silver nitrate is a topical agent that can be used in the treatment of burns. The category of sulfadrugs includes many different drugs. Trimethoprim sulfamethoxazole, or TMP-SMX, is a prominent sulfadrug often tested in the context of its antibiotic properties in the treatment of various infections. Though almost all local anesthetics carry a risk of causing methemoglobinemia, benzocaine is the most well-known and highly tested example. Nitrates and nitrites are notorious for inducing methemoglobinemia on exams as well as in real life. Common sources of nitrates and nitrites include drugs such as nitroglycerin and poorly managed water supplies, as can sometimes be the case with water wells. Lastly, among the various age groups, infants have a higher susceptibility to methemoglobinemia. All right, let's try a question. Why are infants more susceptible to methemoglobinemia following exposures to various oxidizing agents? All right, pause the video and take a second to think about the question. So there are several reasons for this phenomenon. First, the cellular pathways responsible for defending against the effects of oxidation are immature or poorly developed during infancy. An example of such a cellular pathway would be the pentose phosphate pathway, which leads to the production of NADPH. And recall that this is a cellular compound that fuels the antioxidant cellular systems. Second, infants have lower levels of NADH reductase. And recall that this is an enzyme that converts methemoglobin back to hemoglobin. Third, infants have a higher percentage of fetal hemoglobin, which is easier to convert to methemoglobin. Clinically, methemoglobinemia presents as cyanosis, tachycardia, and respiratory distress. This should make sense given that molecules of methemoglobin are unable to efficiently bind and deliver oxygen to tissues. Another particularly high-yield point regarding the clinical presentation of methemoglobinemia is the so-called chocolate-colored blood that can be seen upon a blood draw. Normally, it's hemoglobin that's responsible for giving blood its red color. However, when substantial amounts of hemoglobin are converted to methemoglobin, blood begins to appear more brown or chocolate-colored rather than red. Here's an image illustrating chocolate-colored blood drawn from a patient with methemoglobinemia. The diagnosis of methemoglobinemia typically begins with a history suggesting an exposure to an oxidizing agent, as well as routine pulse oximetry showing low oxygen saturation. It's important to point out that pulse oximetry cannot detect methemoglobin because methemoglobin absorbs the two wavelengths at which pulse oximeters function, leading to erroneous estimations of oxygen saturation. Generally speaking, a high concentration of methemoglobin in the blood causes pulse oximeters to read oxygen saturations as about 85%. The combination of poor oxygen saturation on routine pulse oximetry, as well as no improvement in saturations with oxygen supplementation, should prompt strong suspicion of methemoglobinemia. Once this is suspected, a clinician can use either co-oximetry or an arterial blood gas to confirm the diagnosis. A co-oximeter is a specialized type of a pulse oximeter that functions at a different wavelength and can measure methemoglobin levels directly. If an arterial blood gas is ordered, it can reveal several findings consistent with methemoglobinemia. First, certain blood gas analyzers are equipped to detect methemoglobin directly, in which case the arterial blood gas will reveal elevated levels of methemoglobin. Second, the arterial blood gas will reveal a normal or high PaO2 and a falsely elevated SaO2. PaO2 will be normal or high because patients that appear hypoxic on pulse ox are almost always placed on supplemental oxygen, which will certainly increase the partial pressure of oxygen dissolved in the arterial blood. SaO2 will be falsely elevated because blood gas analyzers typically measure only the PaO2 and subsequently calculate the predicted SaO2 value based on the PaO2. Arterial blood gas showing a falsely elevated oxygen saturation when routine pulse ox shows a low oxygen saturation is known as a saturation gap, and a gap of more than 5% is strongly suggestive of methemoglobinemia. Since methemoglobinemia is caused by an exposure to an oxidizing agent, it's treated by giving patients a reducing agent to reduce ferric iron to ferrous iron, and thus convert methemoglobin back into hemoglobin. The second most commonly used reducing agents for this purpose are IV methylene blue and high-dose vitamin C. All right, let's try another question. A 30-year-old male with a history of leprosy presents to the emergency department in respiratory distress. Review of records indicates the patient was started on treatment for leprosy earlier in the month. Oxygen saturation by routine pulse oximetry is 86%. Arterial blood gas reveals a PaO2 of 95 millimeters of mercury and an SaO2 of 96%. What is the likely diagnosis? All right, the first thing that should stand out about this patient is the difference in oxygen saturation reported on pulse oximetry and the arterial blood gas. Since this difference is greater than 5%, this patient is exhibiting a saturation gap, which means the likely diagnosis is methemoglobinemia. In this particular patient, methemoglobinemia was likely drug-induced, as treatment for leprosy often includes dapsone, which has a known association with methemoglobinemia. All right, now that we've covered methemoglobinemia, let's move on to discuss cyanide poisoning. As with methemoglobinemia, we'll cover the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Cyanide poisoning occurs following exposure to toxic amounts of cyanide. Let's utilize this image illustrating the electron transport chain on the inner mitochondrial membrane to explain the pathophysiology of cyanide poisoning. Normally, a molecule of oxygen gets reduced to a molecule of water in complex 4, thereby completing oxidative phosphorylation and allowing for aerobic metabolism. If cyanide is introduced into the cell, however, it impairs the function of complex 4 and prevents oxygen's participation in the oxidative phosphorylation process. This, in turn, impairs aerobic metabolism, leading to decreased ATP production, increased reliance on anaerobic metabolism, and subsequent lactic acidosis. There are several notable risk factors for cyanide poisoning. A recent history of smoke inhalation in the setting of household fires, especially when carpets or textiles are on fire, should always prompt suspicion of cyanide poisoning. This is because carpets and textiles often contain cyanide, and upon combustion, cyanide gets aerosolized and inhaled as hydrogen cyanide. Occupational exposure to cyanide or hydrogen cyanide can also be seen in mining or when working with pesticides. Lastly, certain drugs carry a risk of causing cyanide poisoning. For example, sodium nitroprusside, which is often used in the treatment of hypertensive emergency, can cause cyanide poisoning. Clinically, cyanide poisoning can manifest in many different ways depending on the body system that's most affected. As the brain gets starved for oxygen, patients may exhibit altered mental status, headaches, or seizures. Early cardiovascular, respiratory, and renal findings include tachycardia, tachypnea, and an anion gap metabolic acidosis secondary to lactic acidosis. These can be later followed by hypotension, arrhythmias, significant respiratory depression, and even renal failure. Accidental ingestion of cyanide can lead to abdominal pain, nausea, and vomiting. Early skin examination may reveal significant flushing, which is often described by examiners as cherry red skin. Later skin examination may reveal cyanosis, or bluish discoloration of the skin. Finally, patients with cyanide poisoning are often described as having either acrid or bitter almond odor on their breath. Here's an example of what cherry red skin can look like. Though this can be seen in cyanide poisoning, This finding is nonspecific, as it can also be seen in other conditions, such as carbon monoxide poisoning. All right, let's try another question. A patient with end-stage renal disease is started on sodium nitroprusside after presenting to the emergency department with a headache and a blood pressure of 202/125 millimeters of mercury. Within the next hour, the patient becomes altered, tachypnic, tachycardic, and experiences a seizure. What is the most likely diagnosis? All right, the patient is likely experiencing acute cyanide poisoning after receiving treatment for hypertensive emergency with sodium nitroprusside. Sodium nitroprusside poses a risk of causing cyanide poisoning because it's metabolized to cyanide by the body. Normally, the metabolites are cleared by the kidneys. In patients with substantial renal disease, however, cyanide can quickly build up in the system, leading to substantial toxicity. This question should serve as a reminder that sodium nitroprusside can cause cyanide toxicity, and that cyanide toxicity is more likely in patients with renal disease. As was the case in the question on the previous slide, cyanide poisoning is typically diagnosed based on high clinical suspicion in the setting of potential recent exposures to cyanide. Though a clinician can order a serum cyanide test, it does not result fast enough to be useful for treatment. Therefore, it's important to treat cyanide toxicity based on high clinical suspicion alone. If labs are drawn, a finding of lactic acidosis would be consistent with cyanide poisoning, as patients rapidly generate lactic acid in the setting of impaired aerobic metabolism. Since cells poisoned with cyanide are not able to use oxygen, the venous oxygen content will increase, which will be evident on a central venous blood gas in the form of a diminished venous arterial PO2 gradient. Lastly, it's important to rule out carbon monoxide poisoning because it can present similarly to cyanide poisoning and can also occur as a result of smoke inhalation. This can be achieved by directly measuring carboxyhemoglobin levels. All right, let's try another question. How will cyanide poisoning affect the difference in oxygen saturation of arterial blood versus venous blood? The difference in oxygen saturation will decrease because cells poisoned with cyanide will not be able to extract oxygen from hemoglobin. Consider an example of what happens normally in the body. Arterial blood, rich in oxygen, is delivered towards tissues where cells extract oxygen, leaving little of it to travel away through the veins and back to the lungs. If cells are poisoned with cyanide, however, tissues will not be able to extract oxygen from the arterial blood, so more oxygen will persist in the venous blood. Hence, if ever presented with venous blood that is rich in oxygen, a clinician should consider the possibility of cyanide poisoning. Management of cyanide poisoning begins with the assessment of the airway, breathing, circulation, and providing respiratory and/or circulatory support with oxygen and fluids, respectively. Initial management should also involve decontamination, such as removing burnt clothing, which can help separate patients from potential sources of cyanide poisoning. Once patients are stabilized, they can be treated further by giving hydroxycobalamin, sodium thiosulfate, or by inducing methemoglobinemia using nitrites. Hydroxycobalamin is a precursor of vitamin B12 that works by binding cyanide to form cyanocobalamin, which is then readily excreted in the urine. Similarly, sodium thiosulfate binds cyanide to form thiocyanate, which is also cleared renally. Induction of methemoglobinemia works because methemoglobin has a high affinity for cyanide and is thus able to extract cyanide from cells, restoring their ability to perform oxidative phosphorylation and aerobic metabolism. All right, now that we've covered the information, let's conclude this lecture with a board-style question. A 25-year-old woman is rescued from a burning apartment complex and rushed to the emergency department due to extensive burns on her extremities. She is in severe pain. Records indicate a history of recurrent UTIs, currently treated with prophylactic trimethoprim sulfamethoxazole. Blood pressure is 140/90 millimeters of mercury, pulse is 110 beats per minute, respiratory rate is 22 breaths per minute, and oxygen saturation by routine pulse oximetry is 95%. Physical examination is notable for extensive burns and respiratory distress. She is started on supplemental oxygen, morphine, and local benzocaine is administered to a particularly severe burn on her right lower leg to help control the pain. As the patient is being prepared for the operating room, she suddenly becomes hypotensive, altered, and struggles to breathe despite supplemental oxygen. Which of the following findings would likely be reported on the venous blood gas collected from this patient? A. Increased levels of carbaminohemoglobin. B. Increased oxygen saturation. C. Decreased oxygen saturation. Or D. Elevated levels of methemoglobin. All right, the correct answer is B. Elevated oxygen saturation. This patient is likely experiencing severe cyanide poisoning, as there are several clues in the vignette that point towards this diagnosis. First, the patient is a victim to a household fire. which means she likely inhaled smoke and was thus exposed to cyanide. Second, she presents with tachycardia and tachypnea, and then later develops hypotension, altered mental status, and respiratory distress, which is consistent with clinical findings seen in patients with cyanide poisoning. Recall that exposure to cyanide renders tissues unable to extract oxygen from hemoglobin, which is why oxygen persists on hemoglobin even when it enters venous blood. Hence, we would expect to see an increased oxygen saturation on a venous blood gas, which is why B is the correct answer. Particularly astute medical students may have been tempted to select option A as the correct answer, knowing that smoke inhalation can also predispose to carbon monoxide poisoning. However, the combination of carbon monoxide and hemoglobin produces a molecule of carboxyhemoglobin, not carbaminohemoglobin. This makes option A incorrect because carbaminohemoglobin is a combination of hemoglobin with carbon dioxide rather than carbon monoxide. Option C is incorrect because, as mentioned earlier, we expect venous oxygen saturation to increase in the setting of cyanide poisoning, not decrease. Option D suggests methemoglobinemia as the underlying diagnosis and is likely a tempting choice due to several clues in the question stem. First, this patient has been taking prophylactic trimethoprim sulfamethoxazole for a long time. Second, the patient received topical benzocaine as part of her pain management, and benzocaine also carries a risk of causing methemoglobinemia. Despite these clues, methemoglobinemia is an unlikely diagnosis for several reasons. First and foremost, the routine pulse oximetry displays a normal oxygen saturation. Recall that pulse oximeters tend to report a saturation of about 85% in patients with methemoglobinemia. Second, methemoglobinemia doesn't usually cause hypotension or altered mental status, although it can certainly cause respiratory distress. So D is incorrect. And again, the correct answer is B, elevated oxygen saturation. And that concludes our lecture on methemoglobinemia and cyanide poisoning.